Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see.
Good afternoon, everyone. Welcome to those of you who are able to join us today during our Lung Cancer Living Room. I'm Danielle Hicks, Chief Patient Officer here at Go-To Foundation for Lung Cancer. And for those of you who aren't familiar with our Living Room program, it's a support and education series created specifically with patients and caregivers in mind, with the goal of bringing to them, live and in real time, educational talks from key opinion leaders in the lung cancer community in a format and in language that's easy to understand. We know that the people watching today come from centers of excellence facilities all around the U.S., and we hope that you will see the incredible value that the Lung Cancer Living Room can bring to the patient and caregiver communities at your facility. We believe that the Lung Cancer Living Room is a place for them to come each month to supplement the wonderful care and education that they receive with you, where they can learn even more about lung cancer, hear directly from thought leaders in the field like yourselves, and connect with each other in order to build community and hope together. Today, we're doing things a little bit differently from what your patients can expect at a normal living room. Although we've invited patients in the past to speak on various panels with expert physicians in the field covering various topics, today, as I said, it's a little different in that our panel is made up entirely of patients. You heard yesterday from Go-To's Leah Fine about the restructure of our COE network and how we hope this new framework will help us meet the diverse and evolving needs of patients by providing access to high-quality patient-centric care. And you've been hearing about the power of together during this year's summit, and what we as a COE community can learn from one another. And today we want you to hear from the patient and see what we can learn from them. They are, after all, at the center of what we do every day. I'm very happy to introduce, and I'm going to let them do a larger introduction because they can do it way better than I, our speakers today. Barry Brinkman, who's a stage 1B lung cancer survivor and advocate. Larry Gershon, who's a stage 4 lung cancer survivor and advocate. And Deirdre Russo, who is also a stage 4 lung cancer survivor and advocate. So with that, and time being of the essence, I'm going to jump right into the conversation, and I'm going to start with Barry. Being a stage 1 survivor, it feels like the appropriate sort of place to start in the flow of this conversation. So, Barry, you were diagnosed at an early stage in May of 2016, I believe. Can you tell us a little bit about how you were diagnosed?
Well, I was living in Dallas, Texas at the time, and the umbrella hospital that I was associated with had sent me a flyer. And basically it said, are you an ex-smoker? I checked yes. Are you over 55? Yes. Have you quit for less than 10 years? Yes. Maybe you need to talk to your general practitioner about getting a low-dose CT scan. So I actually put it off for a couple months. And finally, I gave my GP a call, and she was real good about it. She said, let me call. I'll set it up for you. And within a week, I went to the hospital, had my low-dose CT scan, and they called me 2 days later, said they had found something on my right upper lung lobe. And that was how my journey started with lung cancer. Yes.
Go ahead, please.
No. Well, then she even set me up with the pulmonologist, met the pulmonologist, and that's where I got my real diagnosis that they suspected lung cancer. It was approximately a 1-inch mass, and within a week or two, I had got my PET scan. They had made the determination that the cancer had not spread yet. So I saw a surgeon within another week, was operated within 2 weeks. And so my entire lung cancer treatment journey was from mid-May to basically when I saw the oncologist for the first time at the end of June. And what he said was, we're going to discuss it. We're going to see if the group thinks you need chemotherapy. And the consensus was no. So for the last 5 years, I've been really lucky in that I've just had the follow-up CT scans. And I'm a huge advocate of the low-dose CT scan and how it can make such a difference in your life. And if you fit those qualifications, you really need to do that. And sometimes I think the doctors need to. Yeah.
I agree. I just want to step back a little bit and talk about your screening experience and how you felt, because one of the go-to's goals is to increase the rate of patients diagnosed early. And I want to jump in a little bit to your advice to those out there who may qualify. But how did it feel for you? I know you said it was sort of a serendipitous thing in the way that you ultimately wound up screened. But how did you feel prior to screening? Were you anxious? Were you nervous? Were you concerned about any stigma that might be associated with it?
No, I was actually running probably, 5 to 10 miles a week. I was getting up early, jogging before work. I was exercising. I had no shortness of breath, no pain. So in my mind, I thought, well, this is just going to be another check mark that says, hey, you're healthy and proceed with your life. And instead, it was a huge wake-up call.
Did you have a test for your genomic processing to see if you had a mutation?
No, not that I know of.
So even today,
if they did, I never found out. I can say that.
Yeah, and being a stage one. Oh, go ahead. I'm very sorry.
Well, the other thing is I had a strong history of cancer in my family. Mother, father, great grandparents, some uncles. So even though none of them had lung cancer, I was still aware of that. And so that helped me make that decision to get that low dose CT scan also.
When you went in to get the scan, what was that experience like? Can you talk a little bit about?
It actually took longer to set up the scan than it did to take the scan. And that's the thing that, people need to know that golly, once you go in there, 5 minutes later, you're walking out and it's just no big deal. And I think, it was the donut tube CT scan. It wasn't even the slide in the tube CT scan. So it was really so convenient and so easy. And the fact that it just, I sat in a waiting room longer than the scan, I'll put it that way. So that was really a great thing. And people need to know that. They shouldn't be afraid of that low-dose CT scan.
And then, go ahead. Was somebody going to say something? No. So when you got your results, was it a phone call? Did you have another appointment to come back in?
Well, what happened was the doctor called on a Friday and she said, there's a mass. You need to see the pulmonologist. And it was a long weekend. And then when I saw the pulmonologist, and I think a lot of people can relate to this, when you're told you have lung cancer, it really is like a blow to your head. I felt the blood just drop out of drop. It's a tough thing for people to deal with. That's another reason that the is such a great resource, because I found people I could talk to about it. And, because you have a feeling of blown and out there battling for yourself, even though there's a great team behind you. It's great to have people to relate to. So, and all the resources that I had.
I think it's your journey and your experience um, is somewhat unique in that most people don't have such a positive attitude going into it, um, and there is some fear involved. So, what would your advice be to someone who may qualify for screening?
Well, don't wait. Don't, because I remember, I think it was the surgeon said there was a 2 millimeter difference between where it would have been spread and where it was contained into my lobe. So, if I'd waited another 6 months, my journey would have been completely different. So the minute you're eligible, you need to go in and make that appointment. And don't be afraid of the results, because that's where your treatment starts. And in my case, it was surgery. And I was back at work. The surgery was in the beginning of July, and I was back at work at the end of July. So don't be afraid of getting that scan. That's and encourage your patients to get it if they're eligible. So
I think you make an important point, and so there's roughly 16 million people in the United States right now that currently qualify for screening, and the roundabout average of those that qualify actually getting screened is about 4%, right? So we need to get these screening rates up. What would be your advice to the healthcare providers or suggestions on how they might be able to increase the rates of screening for those that qualify?
Well, in my case, my GP was very encouraging. She said, even though you don't have any symptoms, you're eligible. Call me if you think you need it. And so if you have a patient that you think, even though they're as healthy as a horse the minute you see them, if you think they're eligible, you need to bring that up and let them know, hey, I've looked at your history. You've got, maybe you're an ex-smoker, maybe you're not, maybe your family has a history of cancer, whatever, and suggest that they go in for the scan, because it's not intrusive. It's not, that first scan, they're not doing the injection. They're just doing the lower scan. And as a patient, your patients are going to have a much better journey through any kind of treatment that they find, that they find, because it'll be caught early. The one thing that my oncologist said is, hey, you need to realize that we have a hard time detecting lung cancer because you have no pain receptors in your lungs and you don't feel it until it spreads. And by catching it at stage 1, we're so far ahead of the game in your treatment. And so that is what I would encourage physicians to tell anyone they think is eligible, that by getting this scan, you're going to be ahead of anything that we do find, if we find anything.
Yeah, I couldn't agree with you more. I think it's important that primary care physicians, general practitioners have this conversation with those that qualify. And I know in this meeting in particular, I don't need to go too deep into what that qualifying criteria is. But other than to say that the USPSTF recently changed the guidelines to allow for more people to be eligible. So rather than a 55 year old start date, it's dropped down to 50, and the smoking history is lessened, and all of those things. So I think it's such an important point you make, because quite often when I talk to people about screening, they say, well, how come my general practitioner hasn't mentioned this to me? And I had my own personal experience in going to a doctor's visit for something else, and there was this beautiful poster on the wall starting at birth and running through all of the, between vaccination schedules and screening schedules, at what age it's appropriate. And the one thing missing was lung cancer screening. And so I thought for sure that it was an old poster. And when I looked at it, it was not an old poster, it was a miss. And of course, I got on the phone and called the marketing department and all of that. So I think the more we're talking about it, the more we're thinking about it, the more we'll get the ball moving in the right direction. Barry, before we move on to Larry, I just want to ask you about GoTo and what role GoTo has played, if any, in this process for you. Have you utilized any of our services? Have you found any of them helpful?
Well, I've utilized the group meetings. I've utilized the support, and it's also been an important way for me to communicate with people who have lung cancer and talk about it. And the events, I really, now that I've moved to California, I can go to the Sacramento event, I can go to the San Francisco events, and I really miss the fellowship that we have as a group of people because, we are in this together, and the GoTo Foundation is kind of the glue that helps hold this whole effort together of supporting lung cancer patients. And it's been a great joy to be associated with the GoTo Foundation.
Thank you, Barry.
Thank
I
you.
appreciate your words so much. And this, to coin a very old phrase, it takes a village. And I know how important community is to the patients and caregivers that we work with. So I'm thrilled to hear that you have received benefit and that you are enjoying the community because you are why we do it. Larry, before I jump to you, I was remiss at the beginning in introducing Bonnie, who for most doesn't need any introduction, but she is a 17-year stage 3B lung cancer survivor. She's co-founder and chair of GoTo Foundation and co-moderator of this meeting. So apologize that I forgot to do that. But and any of you, please feel free to chime in as we're going along in this. And if anybody watching has any questions, please feel free to jot those down as well. Larry, let's jump to you. So you had an accidental diagnosis in January of 2013, I believe. Can you walk us through that experience?
Sure. It was accidental. I had a cold. I went to urgent care. The doctor thought it was a good idea to do an x-ray, and that x-ray showed a spot on my right upper lobe, a very small one. So the next step was to do a CT scan, which showed it more clearly, then a PET scan, which showed it was avid and potentially cancerous. It was in the upper right lobe in the mediastinum area. So I did a surgical biopsy of the lymph node adjacent to where the primary was, and it showed adenocarcinoma. Then I had a brain MRI a week later, and there was a 7 millimeter lesion in the occipital lobe. So final staging on Valentine's Day of 2013 was stage 4 lung cancer.
So,
And where are you now, Larry?
Pardon
Where are
me?
you now? Where are you now aside from Hawaii?
Now I experienced a little bit of progression on a scan in August, and I just completed some second opinions and now have a treatment plan in place going forward.
so I think I want to step back before we talk about where you are right now, just a little bit. You talked about once the spot or the lesion was discovered on your lung, some of the diagnostic things that happened next. If memory serves, you went on chemotherapy first, correct? You were not tested for any biomarkers initially?
I actually was tested using the sequential method, not next generation sequencing. Not sure the exact timing of that, but early on, it was determined that I did have an EGFR mutation. But nevertheless, chemo was the first treatment. I did 4 rounds of doublet carboplatin and pemetrexed with good results, and then did the balance of 2012 on maintenance pemetrexed.
And at what point did you go on to a targeted therapy? And how did that sort of come to fruition?
So I did maintenance chemo for, as I said, for the balance of 2013. Then I discussed with my doctor going on a chemo holiday, which I did in 2014. And I was lucky enough not to progress at all until a scan in January of 2015. That showed progression. Since we knew I had the EGFR mutation, we knew that I had Tarceva at that time as an option. So I started on that, and it worked well for 18 months.
And then you went on to Russo very shortly after that. Did you have further biomarker testing, or was this post approval?
So kind of a roundabout situation, but I had a brain metastasis surgically removed in 2016, early 2016, and genomic testing was done, next generation sequencing was done on that. It showed the T790M resistance mutation. So when I systemically progressed in September of 2016, I started on Tagrisso in October of 2016, and I've been on it for 5 years.
You've talked a lot about some of these different treatments that you've had and the journey through this, and you mentioned second opinion. Can you talk a little bit about what those second opinions look like, but how you're still being treated in the community setting?
Yes, my primary oncologist is a general oncologist who treats all types of cancer. And so anytime I've had progression, I've been able to seek second opinions from lung specialists. My most recent round of progression, I've had second opinions from 2 different doctors. Both of them have communicated now back to my primary oncologist with suggestions for future treatment, and she will remain my care, and both of those oncologists have offered to me and to her to follow and be available for consultation and help anytime necessary.
Which is wonderful. It sounds like it's sort of this perfect storm for you to be able to continue to be seen in the community setting where you're comfortable, but also have access to somebody who maybe only specializes in lung cancer. Larry, throughout this entire process, what did good look like for you? And what, if anything, do you wish maybe had been done differently?
Well, good looks like exactly what I did, I think. And I want to credit the Go-To Foundation for educating me, enabling me to have access, to know how to get access to second opinions and to understand my cancer better. Having all of that really made me feel secure throughout my treatment, and still do. I think the one thing that I would have done differently if I had not been so stubborn about not doing it, and for all the wrong reasons, but being involved with palliative care earlier, just because it took me almost 6 years with lung cancer before I actually was actively involved. I was introduced a lot earlier, but for me, the mental piece of it, the support the ongoing accountability to someone in palliative care that I'm staying on the right track nutritionally, physically, getting exercise, and just making sure that I'm doing okay. Checking in with someone on a regular basis.
I think it's really interesting that you bring up the palliative care piece, because I know in talking with patients for the last 15 years or so, that's a big one, because I think there's such a misunderstanding out there about what palliative care actually is, right? People hear palliative care and they automatically think it's hospice or end of life care, and that's so not what palliative care is. It's supportive care, and your story is not uh, just your story. We hear all the time, and we encourage patients all the time to speak with their physicians about palliative care. So, what was it that finally got you to agree to go see a palliative care doctor and see what it was all about?
It was a unfortunate but serendipitous event. I had an automobile accident. I'd passed out. I think I was sleep deprived. I think I fell asleep, but the protocol was to assume that I had a seizure. Through that process, a lot of things happened, but the doctors that were seeing me were very attuned to the fact that palliative care might be very helpful. So that thrust me into it. But from the overall perspective, it would have been better if that had happened about 5 years earlier.
Yeah, I couldn't agree with you more. I think it's go ahead.
It's very important also for patients when they finally get to see an oncologist or the surgical person that you're talking to. It's very important that you ask if they're a specialist in lung cancer. Very, very, very important, because you can be taken down the wrong road really quickly by not seeing a specialist, or making sure that they are willing to get you to one in that event.
I think it's interesting because lung cancer is not just one disease, right? It's so many diseases. And one of the reasons we have our Center of Excellence program is to identify those centers out there that are, practicing excellence and standards of care in lung cancer for their patients. And but it's a challenge, right? And Larry, you mentioned, a general oncologist, and you're right. They do have to treat whatever walks in the door, and lung cancer is tricky. There's not only different types, but different subtypes, and there's a lot of things to know and think. The good news is things are happening fast and furious. The sort of more challenging issue is how everybody can keep up, right? When they don't have the benefit of just being able to treat one disease. So I love the way your story played out, and that you do have a general oncologist who is willing to work with you and sort of this extended care team to ensure that this personalized medicine approach is happening for you. They can consult on that. But then again, you can still get that care. And I know I've said it 3 times, but at the community setting, because we know not only is that where most cancer patients are being treated, but it's where they want to be. It's in their backyard. Not everybody has access, to an academic center that might have specialists in X, Y, or Z cancer. So I think it's, I think it's great the way
you all are. You get to see all those people that Danielle just spoke of, and that you get the right care, because nobody is going to care about you as much as you care about your own treatment and your own care and your own life.
Absolutely. So Larry, I want to talk to you a little bit and ask you the same thing I asked Barry as far as it relates to Go-To Foundation, and what, if any, services that you've utilized, that you've participated in, what have you found helpful?
I don't know that we have enough time to go through the whole list, but I'll start with one-on-one conversations with you and other members of your patient support team to prepare for doctor's visits, to formulate questions so I can get answers that I have about my progression or future treatment options. Um, Equally important, the living room where I've had the opportunity, because I'm local to the San Carlos office, to be there in person when we have had in the past in person living room opportunities to hear thought leaders in the lung cancer area talk and help educate me about my lung cancer and help me advocate for myself. The one other program that I participate in, both I do and my wife does as well, we are phone buddies, where we're matched with lung cancer patients who are having similar type treatments, having similar mutation that we do. It helps them have contact with someone who's walked in their shoes, and it can be comforting for them and rewarding for me to be part of that program. I've also done advocacy with GoTo, speaking to elected officials, national and state officials, elected officials, to advocate for better care, better screening, more funding for lung cancer research. So those are the high points. But in reality, GoTo's become a very important part of my life.
Thanks, Larry. You are advocate extraordinaire, and I know how much effort you put into supporting GoTo and everything you do. And I can't tell you how much, speaking for myself and on behalf of the entire GoTo team, how grateful we are to have been such an important, but more importantly, helpful piece of all of this for you. Because, like I said, lung cancer is not just one disease. Things are happening fast and furiously, and patients don't understand, right? A lot of this language that they're reading, or God forbid they get on Dr. Google and try to, decipher what it is that they're reading there. So to know that we've been able to help you, and then you are now paying it forward, helping other patients who are maybe, more newly diagnosed, not quite so far down the road, and are scared and have questions and maybe aren't quite as educated. So thank you for all you do. So one last question before we move over to Dierdre. What would be your advice to other patients and obviously to the healthcare providers based on your experience? Has there been anything that kind of stands out that you want to share?
For patients, I'll pretty much reiterate some of the things that I've experienced. Educate, learn about your cancer, advocate with your doctor, be proactive, be an active participant in your care. I think back to my parents' generation, and you went to the doctor and the doctor talked to you and you went home. I think that fortunately, patients take a different approach today, and helping to encourage them to do that is something that I try to do quite often as a phone buddy. For the healthcare providers, I think what I would say is just make sure you listen to your patients. Ask them if they're understanding what you're talking about. Make sure that they're engaged, because when you're first diagnosed, you're in the deer in the headlights phase, you hear the C word, your brain goes dead, all of those things. And that doesn't have to be just the first visit, that can be throughout your experience. So making sure they're engaged, making sure they're understanding what's going on. And I would encourage all oncologists to really explain palliative care to their patients and encourage them, help them understand how it can be helpful.
I love that, Larry. And I think, we know that quite often the various members of the healthcare team don't have all the time in the world to sit with every patient. And I think, one of the things that I hope those folks, the centers, the COE centers that are watching today and that may come back and watch later, understand is we really see ourselves as an extension of the care team, not the clinical care team, but the education and support care team that we've been hearing sort of throughout this meeting is oh so important to the patients. And the educated
Patient. You're frozen, Danielle. Okay, well, we can keep chatting until she gets back on. Ditto to everything Danielle said. Ditto to everything Larry and everyone else has said. It's the whole purpose of our centers of excellence is to get the centers of excellence and ones that are not excellent yet up to speed. So you can walk into any one of those community hospitals and get the same care you would get at an academic center. That's a huge, huge job that we are willing to take on. And, a lot about what this meeting is about is make sure that you get the same treatment everybody else does. And isn't that the way it should be regardless? A patient should not have to worry when they walk through a door if they're in the right place. So we're gonna have lots of things to be able to identify these centers of excellence when people walk in, that they're working with us and that they can give that kind of care. Dierdre, can we start talking to you now while we wait for Danielle to go live again? And we're dying to hear your story, not literally.
Sure. Yeah. Hi, my name is Deirdre Russo. I don't know if you have the questions that Danielle had, so I'll try to remember the questions that she asked to my co-cancer buddies. I am 51 years old, and I was diagnosed with stage 4 EGFR exon 19 deletion lung cancer in 2019. Ironically or funnily enough, I don't know what term you want to use, but when I was 48, I woke up on my 48th birthday in July, and I noticed a large lymph node on my neck. And I said to my husband, like, this is it. This is middle age. You wake up one day and boom, cancer. And I actually talked about it with an internist friend, and she said, yes, it's a large node. It could be anything. And I went to my GP, and she said, yes, it's a large node. It could be anything. And she did say weight loss. I said, no. Fatigue, no. Night sweats, no. And that's it. She did not ask me about my family history, which I think was pretty clear in her computer that my mother and her father died of lung cancer. And so the intervening time goes on. I was super busy. I have 2 young kids. I was traveling a lot for work internationally. We were moving, and I started feeling really tired. And then in the spring of 2019, I developed a dry cough, and I thought it was my allergies. I called my GP about my lymph node again, and she did an ultrasound, and she said, it's calcified. And I said, what does that mean? And she said, I don't know. And then I got a new GP because she seemed really not curious about that. And so I went to this new GP, and he did a chest x-ray. There was a finding. He did CT. there was, I didn't know what the results were, and he did a lymph node biopsy. And at this point, a lot of people, myself included, were thinking, and I was hoping, for some kind of TB because I travel a lot internationally for work. And so, long story short, I just felt worse and worse, and I went to my doctor just because I felt so lousy. And my CT had come back. And my actual doctor wasn't in the office. And so I saw someone else, and she said, "Oh, you've had a lot of tests lately. Let me open this up." And she opened up, my electronic medical chart. And then I could just see on her face that something terrible was happening. And she immediately said, "I'm so sorry. I'm so sorry." And, she said, "It's lung cancer. They think you have lung cancer, but we can't. We can't say that for sure until we get your biopsy results." But then she also immediately pivoted and said, "There are great organizations out there. So much is happening in lung cancer. Things are moving so quickly." Um, she said, "There's a professional meeting happening right now in June. They might even have a new protocol for you." She immediately was super positive and said, "Lung cancer is no longer a death sentence. The field is moving really quickly." And, kind of ended on a positive note. And then one thing that I found really difficult is that interim period of basically knowing I had lung cancer based on the CT and then waiting for my pathology results. That was really hard. And it was also really hard just waiting so long to get an oncology appointment. And I should actually preface all of this by saying that I live in Baltimore, Maryland, and I work for Johns Hopkins University. And so I have access to like incredible care. And something that I think has been a salient feature for me throughout my journey is how lucky I am, and how not just luck, but like privileged. And I can't imagine how hard this would be if I didn't have access to the things I have access to, and the colleagues I have, and the favors I can call in. And, it just shouldn't be this way. It should not be so contingent on where you live or who you are or who you know. It should really just be the standard of care for everyone. I know a colleague of mine made a couple phone calls and I got into oncology early. I know she managed to get me like that MRI early. And, that was huge because it was like the longest 2 weeks of my life. And so when my husband and I went to the oncologist, and the fellow walked in, and the first thing she said was, "You probably want to know your MRI results. You don't have brain mets." And I was like so relieved. I burst into tears. And then my oncologist walked in, and she immediately said, "Hello, how are you? I'm so sorry this is happening to you. This must be a shock, et cetera, et cetera." But then she said, "I can't be sure, but given your profile, I am convinced that you have a biomarker or a genetic mutation that's causing your cancer. If you really want to feel like you're doing something and you're freaking out, I can start you on chemotherapy right now. Or if you're willing, you can wait and basically take a blood test or as we call it, a liquid biopsy, and wait to see what the results are. And depending on the results, I can put you on a drug called Russo." And, she was just right out there with kind of like the newest and like best standard of care. And I said, "Of course, I'll wait." Um, and so I just feel like, I've been to many, go to and other groups where you hear people who were diagnosed with pneumonia 5 times and, misdiagnosed. And that just wasn't my experience at all. I mean, I certainly am mad at my GP who let things go for a year, but, yeah, I felt like once I got, into oncology, things went really well. And also immediately, um, my first visit, my oncologist said, "By the way, would you and your husband like to enroll in a palliative care study? And we can randomize you to telehealth or in person." And they immediately explained what palliative care is. It's not hospice. It doesn't mean you're dying, all the health and mental health benefits. And so again, I just feel really lucky that I live where I live.
Well, Dierdre, this
So-
is your story is amazing and quite different than some of the other stories.
Yes, I know. And that's why I
Again,
emphasize my luck, but also that everyone should have this story. Like this should be the standard of care.
exactly. Danielle, I'm sorry. I jumped in in
No,
front of
no,
you.
no, that's okay. I was just going to just ask, Deirdre's opinion, being that, I mean, I know you work in public health and
Hmm.
you have with a heavy focus on health equity. And although, you know, your care once you were diagnosed, I don't want to say seamless, but it progressed as
Hmm.
it should,
Hmm.
right?
Hmm.
Um, what do you think we can do as go-to and with our community to ensure that, or at least to minimize some of those stories that aren't quite like yours or like Larry's or like Barry's
Hmm. I mean, I think a
from a
lot of
public health
I think,
perspective?
yeah, well, I think a lot of provider education, starting in pre-service, let's say medical school, and then also in service. I mean, I think on a public health level, there has to be a lot more public information about stigma and destigmatization. I think the new guidelines are good. When I was diagnosed, I didn't qualify for screening under the old guidelines, but I think there also has to be an emphasis on family history. I often juxtapose my experience getting diagnosed at stage 4 with lung cancer with being a woman with breasts, where you're like bombarded with screening reminders, information, et cetera, et cetera. And so I think that emphasizing screening to providers and looking at family history, and it's not just about a cough, and it's not just if you smoked, or it's not just if you smoked a ton. And family history doesn't just mean if your parents had cancer, it also means if you grew up with cigarette smoke, um, or other environmental factors. So I think looking at stigma across the board, and so people feel more comfortable self-reporting if they did smoke, um, and also working on provider perception and how providers treat people. I was treated so well. Um, and I also was able to get second and third opinions at Mass Gen and Dana-Farber, and people say, "I'm so sorry this happened to you. This must be a shock, and this must have come out of nowhere." But I was sitting in the waiting room with, these old time Boston guys. I'm from Boston, who, were all buddies from jail. They all got lung cancer because all they did is smoke. And, I want them to be told also, this is so awful. It happened to you. I'm so sorry. This must be a shock. So I think it's kind of how people, are treated, dignity and respect. And I was lucky, but I do think a couple of people have mentioned this whole like kind of continuity of care. One thing that's difficult is, you get slotted in with oncology, and so you're only talking to an oncologist. Or I ended up actually leaving the palliative care study because it was so stressful. And stressful because there are so many options, and I'm quote unquote young, or I have young kids. And so I would meet with the palliative care physician, and she would say, "Are you doing yoga? Are you meditating? Are you running? Are you doing this? Are you doing that?" And the irony of Tagrisso is I'm healthy. I don't present sick. I barely took any sick time off of work. And I'm a busy mom of young children who works full time. Like, I joke that in order to really do cancer well, you need to be rich and retired. Both, hopefully. Like, I don't have time to spend every single day, like, doing yoga and acupuncture and all this stuff. And so, that's one thing. Another thing is, even though I have great insurance, um, mental health costs are really, really high. Like yesterday, my daughter was 2 flights up and she heard me do the littlest cough, like, and she yelled down, "Mom, are you okay? Is your cancer getting worse?" And, everyone's in therapy. It's all out of pocket. I think that, kind of insurance and our healthcare industry needs to see that these things are so interrelated, and it's a family disease like a lot of other diseases. So I guess I would just advocate for more continuity of care with the number of providers, and also just the financing, which is beyond me to figure out.
Yeah, I think that's beyond a lot of us to figure out, although
Yeah.
we do work tirelessly with other groups out there to try and, lessen the burden for those that qualify, that we can, based on
Mhm.
what we currently have available, help them with that. I couldn't agree with you more on the
Mhm.
mental health state and treating the whole family.
Mhm.
I want to step back just for a second, because I know um, we've talked a lot about palliative care, which I think is
Mhm.
fantastic. We could do an entire
Mhm.
living room just on palliative
Mhm.
care and the benefits. Um, but what we didn't talk about is sort of this multidisciplinary approach, right? Where
Mhm.
you're not feeling so sort of bucketed, but
Mhm.
rather collaborative decisions are
Mhm.
being made with your care team about your
Mhm.
care. And really,
Mhm.
that starts, if you think about it, with pathology. Your pathologist is the first guy sort of looking at that tissue
Mhm.
and ensuring its quality so that it can be sent out for the biomarker testing that you guys both have been talking about. And then it runs right on down the line, even to some, we talked a little bit about pulmonology, and there's the obvious medical oncologist, radiation
Mhm.
oncologist,
Mhm.
thoracic surgeons, and so on, your nurse navigators.
Mhm.
But even outside of that, what sort of physicians should be on your care team? I know, Larry, you talked early on when you were on Tarsiva about dermatology being a really important piece for you, right? Because
Yes.
of some side effects of medication. And I
It's a
think these
huge
are,
part. It's a huge, sorry.
no, that's
No, I'm
okay.
just
But I
saying
think
for
it's,
me, like dermatology is a huge piece for me onto Grisso. Just there's so
yeah,
many skin things. And then obviously as a woman, and there's the whole OBGYN thing. And
yeah,
um, I mean, one thing that my oncologist says a lot is, my goal, our goal, the community's goal is that this cancer is going to be treated as a chronic disease. And so she always says to me, you need to take care of everything. You can't skip on anything because you think you might die early. And in fact, a month after I got diagnosed, I got something in the mail that said, it's time for your regular mammogram. And I thought, oh, great, whatever. But I went, and as it turns out, my cancer had spread to my breast. And it's not that common. I think it's usually the other way, like Mets,
yeah,
breast to lung.
yeah,
Um, I think it's also important to, if possible, depending on where you live, yes, to have a primary who can work well with your oncologist. Or in my case, my primary is trained as an oncologist, and that's really mattered. I Before I started treatment, my legs hurt so much. I was just in agony. I was in agony. And I called my GP and I just said, my legs just hurt so much. And he said, well, you just had an MRI. They were probably really cramped up in there. And I said, okay. And then um, I sent a my note chart to my oncologist and also this woman who I knew was going to be my new primary, who was trained as an oncologist. And she wrote back immediately and said, I'm sure you have blood clots. You have to go right now and potentially go to the emergency room. And she was right. I had blood clots all up and down my leg. And I just started injecting myself with Lovenox. And he wasn't even thinking that, even though he knew I was going to be diagnosed with cancer because he had the CTs. So it's just like seeing the whole person. And like right
yeah. And
now, I am sorry.
no, go ahead.
Oh, just so, I mean, and again, this is kind of a testament. Like right now, I'm busy working on my visa to go for a work trip to India, and my oncologist and my, primary are emailing with me. My oncologist is like, way to go, no problem. My primary is a little more freaked out about it, but, it's just important that they communicate.
Absolutely, absolutely, and that they know that you're over there, and should you need anything while you're there, make sure you have a plan
Hmm.
for that, and as well. I think this conversation has been so important. We've got about 6 minutes left. I wanted to talk to you, Deirdre, and have you talk a little bit about some of the support that you have gained from the
Hmm.
online communities that you have
Hmm.
participated in. I know we talked about that a little bit before.
I mean, the obvious one of feeling like you're not alone. Um, understanding my disease better, understanding what's out there, getting suggestions about questions to ask, also understanding what a really rough time other people have had. Um, I have particularly enjoyed when I speak to people who quote unquote are younger or maybe really just have younger kids. Because I don't really think about like how many, if I ever do years calculations, I don't think I hope I have 5 years. I kind of count off like if they're 18, it might be better, or out of high school, that's good, or if I could just get them to college. Um, so I think just feeling not alone and seeing the similarity in some of our stories and then also the differences and listening to Larry and Barry, I would love to be a phone buddy, and I would also love to just do more advocacy, like on a political level around funding, more funding for research into this disease.
Well, we can
Well, we would
absolutely help you. Yes, help you get
Yeah,
active in that. And I
yeah,
think
yeah.
I can't tell you how Larry touched on a little bit the phone buddy program and that mentorship, how
hmm
meaningful that is to these folks who, like I said, are earlier
hmm
on, sort of in
hmm
their journey to be able to find that hope. And I feel like this sense of community and how important the lung cancer community is, connecting with other patients. Being able to have those conversations, finding those commonalities is a huge, huge piece of it. So that's one of my big takeaways today, and I'm thrilled to be able to, with GoTo and the rest of our team, be able to provide some of those community engagement opportunities for you. So thank you all for bringing it up. We've got about 4 minutes left, so I'm going to go back and I'm going to run through everyone and just ask if there's any final thoughts. And I see Bonnie wanting to say something.
I just wanted you to let everybody know on screen and off screen that we have a handbook that tells you everything about lung cancer from the day you're diagnosed until your the rest of your journey. So, and they're free to call the help desk. The helpline will mail it to you, and you will put that book down and go, "Wow, I have a lot of questions to ask my physician."
Absolutely. Great point. Great point. So I'm going to give the rest of you about 30 seconds each to just give any final thoughts. Sorry to rush.
I'll go
Barry.
first.
Okay.
One thing that I intended to mention that I forgot in addressing the healthcare professionals is I would really encourage you have a conversation with your patients about how they want to be informed about scans. Many people I talk to have pretty serious scan anxiety, having to wait a week or 2 weeks to get results. I know many healthcare professionals feel like giving bad news needs to be done in person. But I've talked to a lot of people who are content with just knowing the general picture as soon as possible and then having the opportunity to discuss it in detail in a face-to-face appointment.
Beautiful point, Larry. Thank you. Barry, do you have anything you want to add?
You know what? I'd really like to second what Larry just said, because that CT anxiety is probably one of the, after your diagnosis, is one of the worst things you deal with. And in my case, because in all honesty, my treatment has been so much easier than the other two people on this call, is that when I'm told that now my CT scan is going to be on my chart, and then my doctor says, well, if it's bad news, they probably won't put it on my chart. Well, that even makes it worse. I'm not sure how they can come up with a good solution on the whole CT scan issue. But when you get that scan, you instantly are checking online to see what it says. So I'm not sure what they can do about it, but it really is an issue for a lot of us.
Yeah. It's a great point, and we're up for the challenge and working with our centers to figure out maybe what a better way might look like. Dierdre, do you have any final thoughts?
Sorry to have no original thought, but the CT scan is real. And also, I guess it depends on states. My doctor is very clear that she will only share results in person or on the phone. And she will not release results until she's had a chance to talk to me about them. However, at least in Maryland, there's a rule that those results have to be released to your electronic medical chart right away. And so she always says, don't look. And once I looked and once I didn't look. And one thing that I would ask providers is, yes, saying your scans look great is good, but at least if you're me, I've had lots of appointments where they'll say, your scans look great, everything's great. But then I go back and I pore over them, and then I email them like 30 questions.
Yeah.
Oh, you didn't mention that there was a cyst on my kidney, or you didn't mention this, or you didn't mention that. So again, like calibrating to your patient's interest, but it's our body. So just tell us every single thing you see. I've now asked her, like, let's go down. And I've framed it like, this is better for you because you don't want me Googling this and then, inundating you with email. Let's just
Yeah.
get it all out there.
Very, very, very.
It's also good to ask your doctor nicely, what would you do if this was you? How quickly would you want your scan results? What if this was your wife or your husband or your child? Would you want to wait 2 weeks or would you want to right away?
And
Right.
again,
give you a
back to
different
like sorry, one last thing, sorry, but it's like this goes back to like what different cancers. My results are available to me immediately at Johns Hopkins. However, at the screening center that focuses on breast cancer, they have a special like valet service that gets them to you even sooner. And I feel like everyone wants their scans for whatever their potential cancer at the same time.
Yeah.
Right.
And I think there's a lot of what good looks like that we can borrow from other cancers and diseases out there.
Mhm.
I hate to cut this short, everyone, but again, we are about 2 minutes over, and I want to make sure to give the appropriate thanks, obviously to Barry, Dierdre, Larry, and our very own Barney Addario for participating in this conversation today. The entire GoTo team who's out there working every day for our community. A huge thank you to all of you and all you do every day, even outside of this Center of Excellence Summit. To our supporters, Amgen, Daiichi Sankyo, Merck, AstraZeneca, Janssen Oncology, Pfizer, Genentech for supporting this special edition of the Lung Cancer Living Room. Thank you all. And of course, to all of our Center of Excellence centers who are participating in the summit, those who can't, and those who watch this programming today. Enjoy the rest of the meeting, and we will see you guys soon.
The Go-To Foundation for Lung Cancer is connecting our community and giving patients access to free information, resources, and support through various ways. Our helpline is staffed by specially trained Go-To team members and is available to help you address all of your needs, connect you to support, provide you with education, and facilitate referrals. Our free lung cancer education materials provide you with up-to-the-minute information on topics covering the entirety of a lung cancer diagnosis, from screening and early detection and diagnostics to treatment and care. All of our materials are available online for download, or hard copies can be sent to you in the mail. Our Phone Buddy program provides peer-to-peer mentorship and support for people diagnosed with lung cancer who are looking to connect with other survivors like them. This support is provided by trained volunteers who have been there and are ready to help you however they can. The Lung Cancer Living Room is a 3-part support and education series that consists of talks from experts in the field on varying topics. Our virtual social hour, where you can connect and network with other patients, and a breaking news segment to bring you information as it happens in real time. Patients can join one or both of our online lung cancer communities through Health Unlocked or Belong. The communities are online patient-to-patient resources where Go-To Foundation helps to connect patients and caregivers 24/7 for much-needed round-the-clock support. Our Lung Cancer Registry is a place where together patients and caregivers can help build a knowledge base to enable researchers and clinicians to better identify and understand this disease. Through our Lung Cancer Support Group Network, we are able to provide guidance to group leaders and provide patient referrals to lung cancer support groups, including online, telephone, and in-person meetings. Our patient education video library is a place for patients and caregivers to watch archived videos including past educational living rooms, patient stories, breaking news, events, and more. Our Lung Match program is a personalized service that informs and guides patients through the many medical and clinical trial choices, helping you to identify the appropriate treatment options to discuss with your doctor. Go-To Foundation for Lung Cancer is here to support the lung cancer community. Find out more at gotofoundation.org.
Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see.